Thank you, Chairman, and ladies and gentlemen. In the next 20 minutes or so, I'll try to talk about the advocacy in improving the health literacy for our patients. I have no interest to declare, except my interest to be invited again like Agent Liu. My section for today is what, who, why, and how. For what, I will talk about the definition of health literacy. Who, I will talk about two stories to illustrate the health literacy in the kidney health. And the why, we will talk about why we should improve the health literacy and why does it matter for the kidney health. Last, I will talk about some models to improve and enhance the literacy of our patients. So first of all, about the definition, what? In fact, nowadays, the definition of health literacy has been changed. In the old days, we always talk about personal health literacy. That means how the patient are equipped to have ability to find, to understand, and then use information about the health decisions. Now we also change the gear. We say that we also need to think about organization literacy. That means the degree to which we as a health organization to equip our patients with reasonable knowledge and then make sure they understand what we are talking about. So health literacy is no longer a personal attribute, it's an organization attribute. That means we also have the responsibility. And the Chinese translation for health literacy is 健康素養. So they emphasize our people's ability to use information. They focus on ability to make well-informed decisions. And they also acknowledge that the organization has a responsibility to address these issues. And they also incorporate some healthcare, public health perspective. So for the who, I will talk about two pages of mine to illustrate why health literacy is important. The first is a consultation note written by me. I think this is a Malaysian patient. She is a teacher, and then I wrote down insulin at sunset during the fasting month. And the Ramadan fasting will stop next week. So I plan to start the GLP-1 receptor agonist after the Ramadan month. But to my surprise, there was no urine ACR check since 2014. This is a consultation note that I written a few months ago. And she is not aware of the need to have annual ACR check. So this is a public hospital. Now, how to empower patients? I can remember many times that my patient asked me for the next colonoscopy appointment or even pap smear. I can never recall one single patient of mine who asked me when should be the next ACR check. So we are definitely not equipping our patients the knowledge to maintain their kidney health when they have diabetes. So this is the slide I brought from the previous speaker about the need to implement a screening for ACR. Now, I checked at my own, the so-called usual care clinic, not the J program from Julian Chen. I'm talking about the public hospital, a usual general medical clinic. I looked at 4 general medical clinics in my hospital. And then the number of patients who have not a single UCR check for 1 year was as high as 6.2%. So this is really alarming to us. And then the trend was not really improving a lot. There seems to be a little bit of trend improvement in the UCR check, but this is definitely below the standard. And I'm going to tell you another case of mine, also I encountered not too long ago. She's less educated than the previous patients. She has diabetes for more than 10 years. And in 2021, one of the doctors somehow prescribed Granumet and Galvus for her glycemic control. Definitely there's a duplication of the Granu and the Galvus. And subsequently, when another patient saw this patient, he found out, wow, why are you on 2 DPP-4 inhibitors? So he decided to stop one and kept the Granumet, Januvia plus metformin. The patient went home, and she never knew about this, and she found one of the missing medication. She was never informed that she had to stop the Galvus. So when she came back to see me, she brought this drug that she bring with me. She said, doctor, the last doctor forgot to give me these drugs. I have to buy out of my own pocket. Please give me the drugs. So you can see how we should have educated our patients the need to maintain the drugs. So how good are we equipping our patients' knowledge about the drug knowledge? So before this summit, I tried to ask some of the speakers and chairmen for this summit, and how often can a patient with diabetes able to tell the name of drug that she or he is taking? So this is just a casual survey about the percentage of the patients in the public sector that are able to tell the names of the diabetes drugs that they are taking. This is the result. And in fact, Hong Kong, I would say that less than 25% of my patients can tell what drugs they are on. Some countries or regions are better. For example, in Japan, Singapore, they seem to have equipped the patients much better than us. And then I also have a brief survey about how we are giving the investigation result to our patients. So again, I sent some survey to the speakers and chairmen in this summit. If this is a public sector patient, can they assess the laboratory results, such as the HbA1c, the LDL cholesterol? How do they get it? So some of them will receive the information from the doctor during the consultation. Some of them may be able to get electronic email. Some of them may have to apply for extra money. So this is the result. Many of us, the majority, have to ask the doctor, beg the doctors, please give me the result, tell me, can I take a photo, or can you tell me, and then I write down. So most of us have to wait for the doctors. Some of us have some electronic means, and most of them cannot get the result, and even they pay them for the results. So this is the way. Now, why do we have to have health literacy in the outcome of the kidney disease? So I try to see whether there's any evidence to support the relationship between health literacy and the kidney health. So is there any implication on the onset of kidney disease? Is there any implication on the progression of kidney disease? What the effect? Is it a total effect or residual effect? So this is probably one of the best information from Netherlands. They try to look at the implication of low health literacy about the potential risk of onset of kidney disease in the life course. So they try to use some prospectively validate the patient's literacy. They ask simple questions. How often do you have trouble in understanding your medical situation because you have difficulty with written information? How sure are you of yourself when you fill out medical forms? And how often does someone help you with reading information material from hospital? So they just ask this kind of question to differentiate between high and low health literacy. And then they try to prospectively study whether this kind of patient have different onset of CKD. In fact, the health literacy really have implication. You can see that for patients on the right-hand side, the stage 5 CKD, they have much high incidence of low health literacy, up to 50%. And then they further look at the total sample and the elderly patients. They define 65 to be older adults. And then they try to look at the crude model and then the adjust model. At least you can see it in the patient older than 65. Even in adjusted model, a low literacy have a 1.25 odds ratio of onset of kidney disease. So it seems to be really have an influence on the onset of kidney disease. How about progression? Does low health literacy will really make the kidney disease progress faster? I would say that there's many reasons. Apart from the income, pollution, and so on, health literacy is probably one of the key factors. Although in several different issues, they have more definite evidence on the outcome of cardiovascular outcome. But even in end-stage renal failure, I seem to have some study to support the study, the postulation. This comes from the quick study. They try to look at the health literacy on the clinical outcome of kidney disease progression. Of course, they have to look at some confounding factor. In the top, they look at the total effect. They just try to confound the socioeconomic factors about health literacy and the progression of disease. In the model 2, they try to look at the so-called potential mediators. So they look at the BMI and a lot of things that can mediate between the health literacy and the clinical outcome. And again, this is a big study, prospective. So you can see that in the model 1, the top things is the chronic kidney progressions. And the low health literacy really have a hazard ratio of 1.35 on the progression of kidney disease. Of course, there are more important effects on the cardiovascular mortality, as I mentioned. So in patients with limited health literacy, they have increased risk of chronic disease progression. And it's not just the health literacy of the patient, even the parents have the effect. This is a study from Netherlands. They try to look at the pediatric metabolic syndrome. Again, they can show that even the health literacy of the parents make a big difference in the children's health. So it's really important for us to make sure that health literacy is enhanced to improve the kidney health. Now, I will further talk about some digital aid or some tool to enhance health literacy. In the WHO, they define the digital health literacy as the field of knowledge and practice of social development and use of digital technologies to improve health. I think digital health is more and more important, in particular after the COVID pandemic. So we talk about web-based resources, we talk about mobile apps, social network, or even some electronic personal health record. They can try to improve the health knowledge. And many of the speakers for today have mentioned about clinical inertia. Blood pressure is definitely an area that we will have inertia as a doctor to pay attention to. If you have remove the health workers' clinical inertia, you can see in the bottom part, the patient with the so-called SBP more than 140, represented by the orange figure, will be much decreased. So I think structural tools, such as digital aid, will try to get away the clinical inertia because they won't have be so subjective. And therefore, you can see that many of the elderly patients in USA, even in high-income countries, they have clinical inertia, and therefore they never meet the criteria of blood pressure control. Therefore, we need to have some tool which is less biased and data-driven so that we can overcome the clinical inertia, such as a mobile app-based lifestyle modification or other treatment strategy. Then you can also make use of this kind of mobile app to improve the patient behavior and motivate them. And there are many studies such as this kind of apps so that the patient can improve the behavioral change to improve the blood pressure control. So there are lots of studies like this to use a tool for the patient to check their health, and then they motivate them to increase exercise, improve the blood pressure control, and then if needed, we can also assess how good our patient's digital health literacy is like. The most common tool is the so-called eHealth, the so-called eHealth health literacy scale. They ask the patient around 8 questions. For example, how good they are able to find the health resources on the internet. Can they tell which are good quality, which of them are not so good quality in the internet? And then they can use this tool to measure the digital health literacy of the patients. And in fact, this kind of meta-analysis can have proven that the self-monitoring with the mobile app from the smartphone apps has improved of the blood pressure control, although the number is not high, but it's a statistical significance. And there are also some meta-analysis on talking about whether the digital intervention can improve the health literacy. And again, you can see that it is working. So I have tried to look at our own region, Hong Kong. Do we have an app for the patient to download at the smartphone? Recently, the Hong Kong Hospital Authority has introduced a so-called KDIGO, which is an app that the patient can download at the smartphone. And then once they have this smartphone, they can use this to look at the drug that they're taking. And then they can use this tool to look at the main purpose of the drug, name of the drugs that they are taking, what the potential side effects, and then they know more about the knowledge about the drug that they're taking. And they can also check the information about the past record, and also they can even use a medication reminder through the app to teach them when they should take the drugs. And they can even assess the laboratory result, investigation result, so that they can better prepare for the consultation and discuss with the doctor about how to manage the HbA1c. And this is probably a self-reference to drive lifestyle modifications. And for example, this is the app that I download for myself. Once I look at my health, I can choose to look at my record, and then I can easily look at the laboratory result that I have taken, and then I can know the result. Of course, though most of the patients need to be taught how to use this kind of steps, but with more health workers to be volunteered to teach them, I would say that even elderly patients can handle this kind of smartphone nowadays. Hopefully, with this kind of record and drug information, Hong Kong can move a little bit from less than 25 to 50%, and then we will equip our patient to know not just the name, but the purpose and the side effect of drugs. So I would like to conclude here about my talk. For health literacy, we should work to improve both personal health literacy as well as the organization health literacy. And this is relevant to kidney disease health and the management of many chronic diseases. And we should empower patients with knowledge and information. Probably we should make better use of digital platform, which is a potential tool for intervention on health literacy. And the take home is that for the what, we should think about the organization and digital health literacy. For the who, we should apply for all chronic disease. For the why, this is definitely relevant because of the kidney disease onset and progression. And for the health, is talking about the e-health and digital technology. And my last slide is about the KDIGO guideline. They have different pillars of controlling DM. I would advocate to add one more pillar that is an important risk factor for kidney disease progression, which is health literacy that we should work on. Thank you very much for your attention.